Diagnosis of small uterine anatomical variations based on hysterosalpingographic imaging and 2D or 3D ultrasound scans is still difficult, uncertain, and often results in misdiagnosis. Even during hysteroscopy, the golden standard in uterine assessment, the diagnosis depends on operator experience and is therefore not always objective. The prevalence of congenital uterine anomalies has been reported to vary depending on the population and the diagnostic technique used. CUA have been shown to affect 4.3 until 6.7% of the general population and from 3.4 to 8% in infertile population. In women characterized as recurrent aborters, the figure has been reported to be 12.6 until 18.2. Studies comparing reproductive outcome between women with and without uterine anomalies diagnosed during routine hysteroscopy suggest reduced clinical pregnancy rates, increased spontaneous abortion rates, and preterm delivery rates. The first announcement remarked that small, not diagnosed, anatomical abnormalities may play a significant role in implantation failure came with publications of Venetis and Gribisis. The ESHRE-ASG consensus of the classification of female genital tract congenital anomalies brought a new taxonomy system, helping to understand the implication in reproduction better. The more pronounced congenital abnormalities are well known and their negative influence on the implantation process has been statistically confirmed. The new classification focuses also on the new small light categories. These small anatomical variations are expressing different degrees of uterine and endometrial dysfunction. Their influence in the implantation process is probably under-investigated, partially unknown, and underestimated. The method of endometrial scratching is a mechanical endometrial injury which intends to induce desdualization and the healing process, allowing the release of cytokines, growth factors, and other immune modulators to the endometrium in order to facilitate implantation. There is no common consensus about the benefit of endometrial scratching. The most common and controversial issues are underpowered observational studies, many different techniques described in literature, usually performed using a soft plastic PIPEL, endometrial biopsy catheter such as Kaman cannula, Novacurette, and very, very rarely microsurgical hysteroscopic scissors. Differences in the number of times the procedures was performed, the degree of injury, variations in stimulation protocols, differences in timing, problematic control groups, usually RIF patients. A lot of studies, low quality evidence, problematic groups. The majority of the studies refer to PIPEL scratching. To scratch or not to scratch, this is the question. The current evidence is insufficient and conflicting. We really need for well-designed studies, well-powered studies, homogeneous characteristics of study population, carefully selected control groups, subgroup analysis of subfertile couples. Leave both important endpoint. Optimal endometrial injury protocol with regards to technique, type of device, timing, frequency, stimulation protocol, and optimal target patient population. Hysteroscopy allows reliable visual assessment of the cervical canal, uterine cavity for intrauterine adhesions, endometrial polyps, submucous fibroids, endometritis, or uterine malformation that could interfere with implantation. One of the most beneficial impacts of hysteroscopy is the correction of specific uterine cavity abnormalities when detected. Endometrial polyps, different degrees of septum or adhesions are the most common findings in women with implantation failure in the literature. Hysteroscopy provides the opportunity to perform therapy in the same time, such as removing endometrial polyps or submucous fibroids. Therefore, hysteroscopy is currently the only direct method for observing physiological and pathological changes of endometrium, as well as accurate scratching and treatment. Study question: does hysteroscopic endometrial fundus incision in oocyte recipients before embryo transfer increase pregnancy and live birth rates? This study is a retrospective controlled trial involving oocyte receptor patients undergoing embryo transfer during a donation program at Assisting Nature Human Reproduction and Genetics, Thessaloniki, Greece. It was approved by Ethical and Scientific Committee of Assisting Nature Unit. Informed consent was obtained for the patients in the intervention arm. The whole group was 332 egg recipients divided into the two groups, hysteroscopy group 114 and non-hysteroscopy group 218. The women who underwent hysteroscopic evaluation of the uterine cavity prior to ET also underwent fundus endometrial incision irrespective of the presence of arcuate uterus or not with endoscopic scissor. The relation of FEI, performance to pregnancy outcome, was investigated. The age of the woman included into the study ranged from 35 until 50 years old. The mean years of infertility was about 4.6. The mean blastulation rate in our lab with donor eggs was over 59%. 2 blastocyst embryo transfer was performed in all, except for 10 cases with single embryo transfer. The women recruited in the intervention arm of the study commenced OECP on day 2 of the cycle, Yasmin or Labus. Hysteroscopic scissor scratching of fundus endometrial incision, as well called, we performed during the follicular phase of the cycle from day 6 to 10 of the cycle prior to the ET cycle. All frozen cycles were carried out following the same endometrial preparation protocols. Once optimal endometrial thickness achieved over 7 millimeters, daily progesterone, utrogesterone Prolutex was started and ET scheduled. Incision was performed by Wolf endoscopic scissor 2 millimeters using Storz Bertocci 5 millimeters hysteroscope. The endometrial fundus scissor incision was performed in a single straight line from the right fallopian ostium to the left. The dip of incision in case of U0U1C incision was continued with the connective tissue until the appearance of a first vessel. In case of U2A or U2B, the incision was also continued with the same range. And in the case that the septum wall was extracted, the incision was continued through the septum tissue until the appearance of the first vessel also. As you can see here in the video, we are preparing to perform the FE procedure. I choose the middle stage and as you can see that we are working with the scissor a little deeper, creating the cutting line from the one ostium to the other. This is the final view. Among the 140 women in the hysteroscopy group, 65 no uterine anomaly was present. 33 were diagnosed with U2A partial septate arcuate uterus, 10 with U2B complete septate uterus, and 6 women with UIA T-shaped uterus. All women, regardless of the presence of uterine abnormalities or normal cavity, underwent endometrial fundus incision with Wolf endoscopic scissor. Initial positive HCG test was 73.7 in the hysteroscopy group and 57.3 in the non-hysteroscopy group. Live birth rate was higher in the hysteroscopy group than in the non-hysteroscopy group, 56.1 and 42.2, reaching statistical significance with a p-value of 0.015. It has been reported that the prevalence of minor uterine abnormalities identified by hysteroscopy is as high as 30 to 45% under normal transvaginal sonography, and abnormalities found by hysteroscopy are significantly higher in the patients with previous assisted reproduction techniques failure. Two prospective and randomized controlled trials, RCTC, confirmed the value of hysteroscopy in women with RIF by demonstrating significantly increased clinical pregnancy rate. It has also been shown that the fertility-enhancing effect of hysteroscopy could be independent from the correction of uterine abnormalities. Hysteroscopy has been proposed to improve ART outcomes through the endometrial injury process leading to embryo implantation. The time interval between mechanical injury and ET is very important to influence pregnancy outcomes. Comparing to the traditional non-hysteroscopic scratching procedure, the hysteroscopy has been performed during early follicular phase, 1 until 6 months before the start of the new ART cycles based on literature. The techniques of hysteroscopic scratching are not sufficiently described in literature. There isn't any common consensus according to the technique and surgical tools. Our proposed technique, named as Fundus endometrial scissor incision, is performed always in a cycle with OCP, 1 cycle prior or 2 cycles prior to the embryo transfer cycle, in follicular phase of the cycle, day 6 until day 10, in the line from the right opening of the fallopian tube to the left. Incision is continuing within the connective tissue until the appearance of the first vessels. The benefits of technique named as endometrial fundus scissor incision are always in the cycle prior to embryo transfer cycle, giving us the stability and time for inflammatory reaction of the endometrium. In the same follicular part of the cycle from day 6 to day 10, and under the control of contraceptive pills, giving the stability of endometrial growth and thickness. Detailed described technique allowing operators to perform the procedure in the same way. Direct eye-controlled procedure compared to all other techniques of scratching. Thank you very much for your attendance.